tissue layer that lines much of the urinary tract. اليوريثيوم هي عبارة عن البطانة اللي بتكون موجودة بأغلب الجهاز التناسلي الجهاز البولي including the renal pelvis, the ureters, the bladder and parts of the urethra. في تقسيمات الانفكشن تبعت UTI. upper urinary tract infection زي pyelonephritis وعندك lower urinary tract infection like urethritis, prostatitis, cystitis. UTI are much common in women than in men. Up to 33% of all women experience a UTI in their lifetime. The most common UTI is uncomplicated acute cystitis. The majority of UTI are caused by ascending infection from the urethra. Colonization of the vaginal area by pathogens from the fecal flora leads to ascending infection via the urethra into the bladder. Common organisms to make UTI: Escherichia coli, Staphylococcus saprophyticus, and catheter-associated UTI caused by gram-negative bacteria, protease, Klebsiella, and Pseudomonas. Risk factor for the UTI: to the female gender due to the shorter female urethra and vaginal colonization of the bacteria, and sexual intercourse, often the trigger of a UTI in women, honeymoon cystitis. Use of diaphragms and spermicides alters vaginal colonization. For pregnancy and urinary catheter is in hospitalized patients. Personal history of recurrent UTI. Host-dependent factors for recurrent or complicated UTI. Diabetes, patients with spinal cord injuries, and immunocompromised patients. Any structural or functional abnormality that impedes urinary flow, like incomplete voiding, neurogenic bladder, prostatic PPH, vesicourethral reflux, and stones. For male risk factor, uncircumscribed
الختان يعني غير المختونين.
Males colonization of the foreskin.
circumcision ختان.
With sexual intercourse.
Thank you. هلا في كلمة وردت يمكن أثارت شكوكه، هانيمون سيستايتس. بكل كتب الطب راح تقرأوا هانيمون مرتين. مرة هانيمون DM, it is a transient DM due to acute pancreatitis, and after a few months it shifts to whether type 1 or type 2 DM. Honeymoon cystitis, in fact, it is not an infection, it is an inflammation due to the new friction of new intersexual courses between the couples. حبيت أوضحها بس مش أكتر.
clinical features للUTIs. أول شيء dysuria اللي هي burning on urination، برضه في frequency, urgency, suprapubic tenderness, gross hematuria, and lower UTIs fever is absent. بالنسبة للدياجنوسيس، أول شيء ممكن نعمل ديبستيك يوريناليسيس، بكون عندي بوزيتيف يورين لوكوسايت استريز تيست. هذا بحكي لي إنه في presence of leukocyte esterase that reflects pyuria. برضو البوزيتيف نايتريت تيست for presence of bacteria اللي هي الجرام نيجاتيف بالتحديد. النايتريت تيست is sensitive and specific for detecting enterobacteriaceae, but it lacks sensitivity for other organisms. So a negative test should be interpreted with caution. Combining the above two tests yields a sensitivity of 85% and specificity of 75%. هسه بالنسبة لليوريناليسيس في عندي clean catch midstream specimen. أول شيء الadequacy of collection. بحكي له هون إنه presence of epithelial squamous cells indicates valvular or urethral contamination. تكون specimen contaminated. If contamination is suspected, perform a straight catheterization of the bladder عشان أخذ اليورين من البلادر على طول. الكرايتيريا فور UTI، أول شيء عندي البكتيريوريا، بكون more than one organism per oil immersion field. والبكتيريوريا without white blood cells may reflect contamination and is not a reliable indicator of infection. Pyuria is the most valuable finding for diagnosis, greater than or equal to 10 leukocytes per microliter is abnormal. Other findings, hematuria والmytoproteinuria may be present. Hematuria in and of itself does not require extended therapy. بالنسبة للurine gram stain, a count of more than 100,000 organisms per milliliter represents significant bacteriuria. وهذا عنده 90% sensitive و 88% specific. بالنسبة للurine culture, it confirms the diagnosis لأنه عندها high specificity. Obtaining a urine culture is warranted if symptoms are not characteristic of UTI. If a complicated infection is suspected or if symptoms persist despite prior antibiotic therapy or treatment. The traditional criteria إنه more than or equal to 100,000 colony-forming unit per milliliter of urine from a clean catch sample, or misses up to 1/3 of UTIs. Colony counts as low as 1,000 to 10,000 CFU per milliliter are adequate for diagnosis if clinical symptoms are present. We obtain cultures for patients who are over 65 years old, diabetics, واللي عندهم recurrent UTIs, واللي عندهم symptoms for 7 days or more. To diagnose asymptomatic bacteriuria, 2 successive positive cultures, more than 100,000 CFU per milliliter, must be present. Treat asymptomatic bacteriuria only in pregnancy. Blood culture.
Why only in pregnancy? في شيء اسمه asymptomatic bacteriuria in pregnant ladies. It must be treated because it may cause fetal death and abortions. So if the patient, the pregnant lady, is symptomatic or asymptomatic, must be treated. Take care of this point.
The blood cultures only indicated for patient that is ill and urosepsis is suspected. IVP with cystoscopy with excretory urography are not recommended unless structural abnormalities or obstruction is suspected.
So thank you. Thank you.
Acute status that is non-pregnant women, several options exist. Oral TMP, CMX, Bactrim for 3 days, nitrofurantoin 5 to 7 days. Do not give if early pyelonephritis is suspected.
يعني TMP and SMX اختصارات لترايميثوبريم سلفاميثوكسازول. اسم التجاري باكترم بالصيدليات.
Fosfomycin single dose. Do not give if early pyelonephritis. Amoxicillin is a less popular alternative to increasing antimicrobial resistance. Quinolones, ciprofloxacin, and 3 reasonable alternative to the above mentioned. Treat presumptively for pyelonephritis if a condition of antibiotics. Zopyridine is a urinary analgesic. It can be given for 1 to 3 days for dysuria. Pregnant women with UTI treat with amoxicillin or oral cephalosporins for 7 to 10 days.
Why ampicillin or amoxicillin?
Okay, teratogenic.
Not teratogenic. Non-teratogenic.
For pregnant, okay, non-teratogenic, yes, not. Avoid fluoroquinolones, teratogenic.
Because the fluoroquinolones can cause arthropathy in the fetus.
UTIs in men treat as with uncomplicated cystitis in women, but for 7 days. Urologic workup is required in all men presented with UTI unless there is an obvious underlying risk factor, catheterization, etc. Recurrent infections. If relapse occurs within 2 weeks of cessation of treatment, continue treatment for 2 more weeks and obtain a urine culture. Otherwise, treat as for uncomplicated cystitis. If the patient has more than 2 UTIs per year, give chemoprophylaxis.
Hemoprophylaxis.
General characteristics. Pyelonephritis is an infection of the upper urinary tract. It's usually caused by ascending spread from the bladder to the kidney. Or uncomplicated pyelonephritis is limited to the renal pyelocalyceal medullary region. Vesicoureteral reflex facilitates this ascending spread. E. coli, most frequent cause. Other gram-negative bacteria include Proteus, Klebsiella enterobacter, and Pseudomonas species. Gram-positive bacteria, less common, include Enterococcus fecalis and Staph aureus. Complications, unusual. Sepsis occurs in 10 to 25% of patients with pyelonephritis, may lead to shock. Emphysematous pyelonephritis caused
Please
by...
keep quiet, please, and listen.
Caused by gas-producing bacteria in diabetic patients. Chronic pyelonephritis and scarring of the kidneys, rare unless underlying renal disease exists.
Thank you so much.
عندنا the clinical features, its symptoms, عندنا بيكون fever, chills, flank pain, symptoms of cystitis may or may not be present, nausea and vomiting and diarrhea, sometimes present. Signs.
And look, sometimes UTI can cause diarrhea, which is odd, but it is a symptom, not yet known.
عندنا signs, fever with tachycardia. Patient generally appear more ill than patient with cystitis. Costovertebral angle tenderness, unilateral or bilateral. Abdominal tenderness may be present on examination. Diagnosis, urine analysis. Look for pyuria, bacteria, and leukocyte casts. As in cystitis, hematuria and mild proteinuria may be present. Urine cultures obtained in all patients with suspected pyelonephritis. Blood cultures obtained in ill-appearing patients and all hospitalized patients. CBC, leukocytosis with lift shift. Renal function, this is usually preserved. Impairment is usually reversible, especially with IV fluids. Imaging studies. Perform these if treatment fails or in any patient with complicated pyelonephritis. Consider renal ultrasound, CT, IVP, or retrograde ureterogram. Treatment. For uncomplicated pyelonephritis, use outpatient treatment if the patient can take oral antibiotics. Treat based on gram stain. Trimethoprim or sulfamethyl.
Trimethoprim, sulfametazole.
Okay, or fluoroquinolone for 10 to 14 days is effective for most gram-negative rods. Amoxicillin is appropriate for gram-positive cocci. Enterococci S. saprophyticus.
Staph saprophyticus. درست bacteriology, microbiology.
A single dose of ceftriaxone or gentamicin is often given initially before starting oral treatment. Repeat urine culture for 2 to 4 days after cessation of therapy. If symptoms fail or resolve within 48 hours, adjust treatment based on urine culture. Fail to respond to appropriate antimicrobial therapy, suggest a functional or structural abnormality. Perform a urological investigation. If the patient is very elderly, pregnant, unable to tolerate oral meds, or has significant comorbidities, or if urosepsis is suspected. Hospitalize the patient and give IV fluids. Treat with antibiotics. Start with parenteral antibiotics, broad spectrum, ampicillin plus gentamicin, or ciprofloxacin are common initial choices. If blood culture are negative, treat with IV antibiotic until the patient is afebrile for 24 hours. Then give oral antibiotics to complete a 14 to 21 day course. If blood culture are positive, treat with IV antibiotics for 2 to 3 weeks. For recurrent pyelonephritis, if relapse is due to the same organism despite appropriate treatment, treat for 6 weeks. If relapse is due to a new organism, treat with appropriate therapy for 2 weeks.
Thank you, Doctora. UTI is very common disease, especially in ladies, as you know, in females, because female has many risk factors to get UTI. But the man is less frequent or less liable to get UTI. In your own clinics in the future, 20% of your patients will be UTI patients. And I see it in my clinic. Most of females come to nephrology or urology are due to UTI or recurrent UTI. So take it seriously, that subject. And another point, if a urine culture showed UTI in a lady and you have given the appropriate antibiotic according to the culture and she finishes the course of management, don't consider that she is cured. You have to reculture her urine after 2 to 4 days. If the reculture showed no growth, then she is cured. And if it showed some pathogen, you have to retreat again. From the 6 lectures today, anyone wants to ask any question or any inquiry? Everything, I hope, is understood. Yes. I'll remind you that 20 MCQs in the written exam will be from those 6 lectures. So anyone who has got it correctly, he will get the 20 marks. Take care. هلا وقت الحضور